Today, today's topic is drugs for neurodegenerative diseases, and with this topic, we are starting the section Central Nervous System drugs, and drugs for neurodegenerative diseases include anti-Parkinson drugs, and this is most studied disease because Parkinson disease was first discovered in 50s in 1950s, and first drugs appeared in 70s, and now there are almost more than uh, 10 drugs for the treatment of the Parkinson disease, and many companies are producing the levodopa that is usually administered with the carbidopa, and many other drugs that influence the dopaminergic system, so or the cholinergic system, that is most important systems in during the Parkinson disease development. And then recently the drugs for the Alzheimer disease appeared at the market and become commercially available, and this include galantamine and rivastigmine, and also donepezil and memantine. And then besides these two diseases, Parkinson's disease and Alzheimer disease, both are disabling diseases and usually seen in old patients, so especially Alzheimer disease only seen in old patients. Parkinson's disease can be seen in young patients and children as well, but mostly in but more frequently in elderly. Then drugs for the multiple sclerosis are also available now, and also uh, drugs for the amyotrophic sclerosis are also available, but have a limited availability at the moment. So uh, nevertheless, the drugs for the sclerosis uh, uh, are less effective than for the other diseases, like for example anti-Parkinson drugs, and are still uh, under investigation. So that is why we will start with the Parkinson disease, because it's most commonly treated disease of the central nervous system that is a degenerative, and there are many drugs for the treatment. But today but before starting, we will focus on the reasons for the development of the Parkinson disease. So, and then, and the first reason is the uh, less loss of dopamine uh, in the neurostriatum, that is part of the brain, and the stimulatory uh, acetylcholine uh, neurons will increase firing because of the decrease of the inhibitory dopaminergic neuron innervation, and that may lead to the disruption in the skeletal muscle uh, interaction control, and that increases acetylcholine release in the central nervous system and firing of the neurons that uh, control the muscle movement, and also I'm sorry and also it increases the inhibitory gamma aminobutyric acid neurons transmission, and that further inhibits the dopaminergic neurons. So, but initially the disease is developed because of the decrease in dopamine release, because of the dopaminergic neurons decrease for some reason, most commonly immuno uh, 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 be, most commonly because of the uh, antibodies are synthesized against the dopaminergic neurons, and the immunity of the body will reduce the number of the dopaminergic neurons. So that is why primary treatment for the Parkinson's disease is increase in the levels of the dopamine, and because dopamine is uh, impermeable for the blood-brain barrier, instead we administer a levodopa. So levodopa is uh, the deoxyphenylalanine with the left isomer of the left isomer of the deoxyphenylalanine. So this is a drug that is administered orally, and when administered orally, levodopa is metabolized in the GI and peripheral tissues, and that results in the side effects at the periphery, and it metabolizes to dopamine, and as far as you know, the dopamine is adrenergic agonist, and that leads to the side effects of the at the peripheral nervous system that is connected with the activation of the sympathetic nervous system. So the heart rate increase, the GI disturbances, so this will lead to the adverse effect. So that is why most of the time the levodopa is administered with the carbidopa. So carbidopa is antagonist of the uh, uh, enzyme that converts levodopa at the periphery, and that decreases metabolism of the levodopa in the GI and in the blood, and that leads to the high levels of the uh, levodopa in the brain, because more levodopa will pass the blood-brain barrier, and then can be converted to dopamine in the central nervous system, and that helps first to reduce the dose of the levodopa, so we don't need much levodopa like without carbidopa, and then also decreases the side effects at the periphery and GI side effects that are not easily overcome by the patient. So the patient actually will not uh, tolerate well these adverse effects. So that is why most of the patients will prefer levodopa plus carbidopa. So and the adverse effects of the levodopa include nausea and vomiting, because administered orally, tachycardia. This results from the dopamine that is converted at the peripheral nervous system, uh, that is produced at the peripheral nervous system. Then reflex hypotension, and also some psychiatric problems because of the increase of the dopamine in central nervous system. So, so these are the side effects. And levodopa also will can interfere with other drugs like the monoamino oxidase inhibitors, so that leads to the hypertensive crisis because the level of the catecholamines is increased. So that is why should not be administered together with the uh, monoamino oxidase inhibitors, like for example these drugs are uh, or antidepressant drugs, and then also will increase the pyridoxine levels because of the decreasing the metabolism of the pyridoxine, so should not be administered together as well. So the uh, um, and increase in the dopamine is because of the uh, uh, because of the MAO-B inhibition by the uh, by the drugs like for example salicylic can be used also for the treatment of the Parkinson disease. So the previous drug levodopa increased the dopamine levels by uh, in, uh, increasing the deoxyphenylalanine that is converted to the dopamine. So this is the first approach. So the second approach for the treatment is decrease the metabolism of the dopamine that is produced in the central nervous system by inhibiting the MAO-B, that is so monoamino oxidase type B is most uh, active enzyme that metabolizes the dopamine in the central nervous system. So this is the second approach to decrease the metabolism of the dopamine. So high concentrations of dopamine are seen in the central nervous system that helps to decrease the symptoms of the Parkinson's disease. So salicylic and other MAO inhibitors can be used and are effective for the treatment of the Parkinson's disease, but they are less effective than levodopa. And that is why most commonly levodopa is still most common on the administered drug and also used uh, more frequently for the treatment. And so also Razagiline has the same action, so is uh, inhibits monoamino oxidase type B, uh, and it also inhibits monoamino oxidase type A uh, that metabolize norepinephrine and serotonin, but in less amount. So especially when used in low doses, in recommended doses, there is selectivity to MAO-A that metabolizes dopamine. So the dopamine levels are increased. So and that increases levels of the dopamine in the brain. Aceclidine can be also administered together with the levodopa, and it increases the activity of levodopa, and we can also decrease the dose of levodopa in case of the adverse effects. So this combined regime of treatment can be very beneficial for the patient because of the low adverse effects profile. Because Celegreen itself is also almost no adverse effects in low doses, so it's much better and much better tolerated than levodopa. Uh, so and uh, Non-selective monoamino oxidase inhibitors have more adverse effects, including the increase in the blood pressure, and that is why I'll not recommend it at the moment. Sertraline is metabolized to methamphetamine and amphetamine, and they also stimulate central nervous system and can lead to the insomnia, especially if administered uh, afternoon. So that is why it's recommended to administer at the morning instead. And Rosagirin and uh, uh, Rosagirin, that is another drug from the same group, MAO-B inhibitor, is an irreversible inhibitor, and yeah, it has higher activity than selegiline, uh, and is not metabolized to amphetamine, so can be administered before the bedtime as well. Then there are also catechol or methyltransferase inhibitors. So and normally uh, the methylation of levodopa by catechol or methyltransferase is not a major way of metabolism of the levodopa, but when we uh, uh, block uh, the other enzymes with the carbidopa, then it becomes the way of the metabolism, uh, and uh, uh, and met, 3-O-methyldopa, that is the metabolite of both the catechol or metyl transferase, and is produced, and it competes with the levodopa for the transfer to the central nervous system. And to reduce the entacapone and tolcapone are used that are selectively block catechol or metyl transferase, and reduce the production of the 3-O-methyl-dopa, and that will increase levodopa permeability to the central nervous system, and also reduce the metabolism in the peripheral tissues and GI. So entacapone and tolcapone can be administered together with the levodopa to further increase its activity and decrease the adverse effects. And the uh, these drugs are also they are given orally, and they are bound to the blood proteins, and uh, adverse effects include so adverse effects are the same as with the levodopa, usually diarrhea, hypotension, nausea, vomiting, hallucinations, and sleep disorders. So uh, sleep disorders are the same as with the selegiline. Uh, then tolcapone also can lead to the nephrosis, so should be avoided in patients with hepatic disease. And entacapone is more safe and don't have these adverse effects. That is why it's recommended for the use. And also So here the adverse effects of the drugs are listed. And the next group is also dopamine receptor agonist, and these include bromocriptine, and that is a derivative of the ergot, like ergotamine, obtained from the plant, not the plant, but by from the ergot that is cultivated in plants, and also non-ergot alkaloid uh, others are non-ergot like uh, the rotigotine and pramipexole, and also apomorphine. Apomorphine is the derivative of the morphine that recently synthesized, and these agents have longer duration of action because levodopa is metabolized fast and requires frequent dosing, but these drugs are long acting, and uh, that is why have less risk of dyskinesia and the switch on off symptoms that's seen with the levodopa, especially at the beginning of the treatment. And that is why these drugs are very effective and usually used in patients that are not tolerate levodopa or when the levodopa is not effective. Apomorphine are used as injectable, and it has usually used in advanced stage Parkinson's disease when other drugs are not effective or are not tolerated, and side effects are actually here the same: sedation, hallucinations, confusion, nausea, vomiting, and postural hypotension. So and the uh, next group is Amantandin. Amantandin is an antiviral disease. So sorry, an antiviral drug. And uh, initially was developed as an antiviral drug, so for the flu, for the treatment of common cold, mostly, and but effectiveness during the uh, cold is very low for the flu as well. But patients with the Parkinson disease that administered amantadine for the treatment of the flu uh, reported reduction in the Parkinson disease symptoms, and that is why uh, nowadays amantadine is used as anti-Parkinson disease. So, and its effect was accidentally discovered. Uh, because it's initially developed as for the drugs for the flu, so and for the influenza, but has anti-Parkinsonian action, and the mechanism of action is not uh, is not known exactly, but is connected to the release of the dopamine, blocking cholinergic receptors, and also NMDA receptors that are receptors for the glutamate or GABA receptors. Uh, and the recent research suppose that NMDA receptors are the most important. That is why actually at least here we add a GABA neurons, so these GABA neurons were not here in place like about 10 years ago, for example, when the amantadine actually effect was not so prominent. So and the adverse effects are the same, like hallucinations, confusion, especially at high doses, and higher orthostatic hypotension, and edema, dry mouth, and so these are but adverse effects are lower than with the levodopa and is tolerated better. Uh, so then, and the last but not the least are anti-muscarinic agents. So these are less efficient than levodopa and usually used only in combination. So this includes benztropine, 3-hexyphenadiol, procyclidine, and piperidine. So these drugs, we already studied benztropine because benztropine is the derivative of the atropine. So atropine is a classic anti-muscarinic agent. So and benztropine is longer acting central nervous system permeable drug. Uh, and these drugs are reducing the cholinergic transmission that is increased during the Parkinson disease, and this recovers the balance between the dopamine and acetylcholine. So when we have dopaminergic and acetylcholinergic that actually inhibit each other, so when we have less dopamine in substantia nigra, then acetylcholine firing increases in the neurostriatum and is firing very fast, and then will lead to the inhibition of the substantia nigra, and that will further inhibit the neurostriatum. So that is why we block the uh, benztropine that blocks the acetylcholine, so firing is decreases, and that is why it will not block the substantia nigra. So balance between the neurostriatum and substantia nigra will recover for the limited amount of time. So this is actually a very simple explanation because actually uh, the the true uh, uh, mechanism is more complicated and actually is not cannot be understood. Uh, uh, so very complicated. The adverse effects actually include those seen with the acetylcholine inhibitors, like tremors, bradycardia, nausea, vomiting, diarrhea, decrease in the appetite or anorexia, and also muscle pain. So uh, this group of the drugs has highest adverse effects, and that is why it's seldom used, and also dryness in the mouth and dryness of the eyes can be seen. So most commonly adverse effect that is uh, reported is the constipation from the patients. So and also this group of drug is contraindicated with the glaucoma patients, so patients with the increased eye intraocular pressure, glaucoma, then also with the prostatic hyperplasia. So prostatic hyperplasia is seen in usually in elderly, in old men, uh, and treated with the tamsulosin. We also discussed this disease, and also so glaucoma we also discussed. So it's treated with the pilocarpine, and also the atropine is contraindicated because it will lead to the closing of the angle of the eye because of the mydriasis. So these are the Parkinson disease drugs. The Alzheimer disease or dementia is the one of the most disabling diseases that only seen in old patients. Old patients will mean 70 something, 80 something. So usually it's not seen until the 50s something. Uh, the development of Alzheimer's disease is connected with the loss of memory, and the patients will forget the people they know. So and many uh, many famous people are known to have Alzheimer's disease, including the American presidents and then the actors. So actually, it's very disabling disease, and that is why um, uh, much effort is uh, directed towards the development of the diseases, because sooner or later all of us will develop Alzheimer's disease. So that is only the matter of time. So if we don't die from other diseases until the 60s or 70s, then we will probably develop this disease. So someone will develop earlier, someone will develop it later. But so if you will not die in a car accident or from the cardiovascular disease, then you will probably die from Alzheimer. So you will not die, but at least like you will lose your consciousness, and also you will forget your relatives, and actually will be very uh, hmm, uh, so very uh, disabled patients. And the reason for the development of the disease is connected with the uh, formation of the fibrillary tangles and loss of cortical neurons, so especially cholinergic neurons. And that is why most of the drugs are directed towards increasing the cholinergic transmission in the central nervous system, and also for the decrease in the NMDA receptors that are inhibiting some glutamate, NMDA glutamate receptors. So NMDA is the type of the receptor, and glutamate is a neurotransmitter, and it is an inhibiting neurotransmitter in the central nervous system. So pramipexole and ropinirole are the primary used drugs, and these are actually uh, usually used uh, in combinations with the levodopa, and usually when the disease is mild, and also at the younger age, and that actually uh, administration of these drugs may delay the starting of levodopa. So uh, the uh, anticholinesterase inhibitors are also used for the treatment of the Alzheimer's disease. And uh, because the cholinergic neurons are lost, and uh, uh, that is why anticholinesterase that decreases, so that metabolizes acetylcholine, will be less effective, and more acetylcholine will be preserved in the central nervous system, and that increases the cholinergic activation in the central nervous system and helps with the Alzheimer's disease. Uh, but that will not prevent the uh, the progression of the disease, because the cholinergic neurons will decrease, and eventually there will be no cholinergic neurons left. So that's why at that stage, so uh, at the late stages, acetylcholinesterase inhibitors are not as effective. Uh, and that is why only used for the treatment of the mild infections in young patients. Uh, and the drugs include galantamine, anti-histamine, uh, and uh, these drugs uh, decrease the progression of the Alzheimer disease, but they don't treat the disease. So, and also can be used for the Parkinson's disease. So adverse effects are listed here. So these include tremors, bradycardia, nausea, vomiting, diarrhea, anorexia, and myalgia. So then the drugs for the treatment of the multiple sclerosis are, so there are two types of the sclerosis, multiple sclerosis uh, and uh, the amyotrophic lateral sclerosis. So multiple sclerosis uh, is the uh, progressive disease, and it is autoimmune disease that leads to the inflammation in the central nervous system, and usually starts with the acute episode and then becomes chronic or progressive disease that can develop during the 10 and more years. And because it's uh, because it's inflammatory disease, then corticosteroids can be used for the treatment that are dexamethasone and prednisolone that administered uh, orally and used for the as anti-inflammatory drugs in the periphery, also effective for the central nervous system diseases, and also cyclophosphamide and azathioprine can be used for the treatment. Also, other drugs including the interferons alpha and interferons beta 1A and beta 1B can be used as a immunomodulatory agent to decrease the inflammation. Then uh, many other uh, antibodies can be used for the decrease in the inflammation and in the cytotoxic effects that are all the cells that included participating in the development of the inflammation. So uh, these drugs are more expensive and usually used for the treatment of the cancer, but still can be used for the multiple sclerosis as well. Then symptomatic treatment can include the drugs for the decrease of the constipation and depression and bladder dysfunction and for example uh, dalfampridine, that is a potassium channel blocker, can improve the walking speeds and in patients with the multiple sclerosis. And someone is late for the lecture, so we are almost at the end. And then also the last disease, amyotrophic lateral sclerosis, or ALS, is also a sclerosis that is connected with the degeneration of the neurons and mostly by the motor neurons, and two drugs are used, riluzolone, and that is NMDA receptor antagonist. Uh, the drug is new and we don't know much about the drug, and it's probably effective, but it is not clear at the moment. So that is it for today. Thank you for your attention, and if you have any questions or comments, feel free to fill them below.